from Sam Profit, Finance Director, but we have Andrew Harrison, Director of Finance, deputising on Sam's behalf. Sorry, Sam, of course, is the CFO. And Jane O'Brien, non-executive member. We've also got apologies from regular participant Tracy Hopkins, and that's the only other apology that we've received. So we've got a good turnout. The meeting is quorate. We're going to start, as we always start, with a patient story. And we're going to hear the experience from a resident of East Lancashire who describes her experience of care for her husband, who sadly died from terminal cancer, and her experiences as an older person who lives alone. I'm going to ask Sarah O'Brien to introduce the story, which highlights the need to improve end-of-life care. We've also got a focus today on our acute clinical vision for Lancashire and South Cumbria and our ambition to reduce health inequalities for our residents. As always, I wish to maximise time for discussion, so I would urge all those presenting papers to keep introductions to a minimum. You can assume that we've all read the papers diligently so that we can use the time for discussion as a board. And then I'd just like to say we've had one question from a member of the public in relation to thrombectomy services, and it directly pertains to today's meeting. It's at agenda item 12C, Committee Escalation and Assurance Reports from the Quality Committee. We will refer to this question when we come to that item. And finally, declarations of interest. We've not been informed of any. Are there any? Yes.
Apologies, it's not a declaration of interest of items on the agenda. It's just for the board to note that I will be updating my register of interest for the board as I'm moving from one trust to another voluntary organisation.
Okay, thank you. Thank you very much. Okay, so I think we can therefore move on to the standing items. So we've got minutes of the meetings on the meeting held on the 13th of November. Can I just ask, are there any questions of accuracy first of all? No. Any matters arising not raised that should have been raised? No. So happy to sign that off. Good. And then we just do the action log. Remind me, where are we? All actions have proposals to address, and I'm proposing, therefore, that they are closed. Is everybody happy with that? Great, excellent. So if we can move then to the patient story. Over to you, Sarah. Thank you.
Thank you, Chair. I just before we put the video on, I just want to start by thanking Mrs. A, who is a resident of East Lancashire, and she came forward to us during one of our community engagement events, keen to share her family's experiences. So she's going to talk about a couple of members of her family and their experiences of health services. And like many of the stories we get at board, while there's quite a lot of positive in there, particularly in terms of the experience of the direct care given, the experience of how joined up health services were and some of the communication were less than where we would probably aspire for them to be, which is not an uncommon theme. So I think the variation in services comes out, the lack of joined upness between some of our services also comes out, and communication. I think this story is really pertinent today given some of the agenda items, particularly around the clinical services reconfiguration and inequalities in health. I think they're all relevant, and I think what we need to do when we're doing those pieces of work as a system is keep our patients and residents like Mrs. A firmly at the front of everything we're doing, so that the impact of what we're doing not only is going to improve outcomes, but actually is going to mean that people have an exemplary experience of care. Thank you.
I've lived in East Lancashire all my life. I am lucky that my health has been reasonably good. However, my husband sadly had terminal cancer later in life. My personal experience of the health service when my husband was dying was very good. When my husband was approaching end of life, he wanted to be at home. That was accepted and supported by everyone. It felt as if everything was integrated and joined up. Everyone played their role with good communication. Everything was put in place, and everyone followed through with what was promised. We had community physio, a dietitian, the district nurse, palliative care professionals, and the GP. The care was excellent. They all seemed to know what each other was doing, which helped considerably. Sadly, my husband died, but I know that everyone did everything they could to make his last few months easy and comfortable for him and for me. When things go well, the health service is excellent. When things don't go so well, it can be hard work. Recently, my daughter had a difficult time with her hospital, and one of my elderly relatives had a very chaotic discharge from hospital. She received a text message to confirm a hospital appointment for a blood test, followed by an email letter. She then got a cancellation message quickly by text. This was followed by 2 reminders for the appointment, which had been cancelled. We got duplicate letters, poorly written and with conflicting information about appointment times and locations, all very confusing. We went round and round in circles for basic requests. As an older person who lives alone, I now worry about the emphasis on digital this and digital that. There's more of an emphasis on the computer rather than the individual who turns up. The computer seems more important, but IT systems don't seem to work well. I understand the reliance on computerised letters, emails and texts, but I worry about how it works, as experiences from my family recently have not been good. Everyone expects me to use my phone to sort out appointments and prescriptions and information, but I worry about scams and I'm afraid of doing something wrong. I've got arthritis in my hands and it takes me much longer to do things. Although I do have a computer, it was my husband's and I don't use it much. If you are going to use more technology and computers, you need to make sure we are trained and feel safe. When you get and receive the care, it is usually excellent. The support services and the administration around the care could be improved. I've lived in East Lancashire.
Thank you, Sarah. Was there anything you
Well,
wanted
just
to
to
add?
say, I think she said it in her own words, didn't she? And it's really reassuring when you hear a really positive experience of end-of-life care, because it is one of our priorities, and we do know we've got variance in that across the patch. But I think what you've got there is somebody who, her and her family have had that variance, and I think it's really important as we move forward and transform that we try and get a more consistent offer so that there's a consistency in experience for people. It was also interesting to get the other side of the digital agenda, because we talk a lot about what we could do with digital to enable how we do it, but there you heard from somebody who actually has got some nervousness around digital, so it's really important we make that person-centred.
Absolutely, absolutely. Any other board thoughts on the patient's story? Asim, thank you.
Thank you, Chair. And I think just to reiterate what Sarah said, I think that in terms of the end-of-life care positive story, that was also most probably impacted by digital, by having a digital end-of-life care plan that is shared across all of our providers, would have really contributed to the positive experience that the husband received. And we do look at this. We look at in our integrated performance report in terms of end-of-life care planning, because I do believe that is fundamental to get all of the agencies joined up and deliver the care at the most sort of time when it's really required. In terms of the latter part of the story around the correspondence and digital correspondence, I think just to give assurance to the board. Yeah, so this is about choice. So there's 4 different systems across all our 4 hospital providers. We are looking at having a single system in due time. But it's not that these individuals don't receive a letter. So a letter will go out on a digital format, and if that letter is not accessed, then the patient will receive a letter by post. But what we are seeing, this is empowering people, is reducing the number of DNAs, and is actually, when it's used right, is making a positive impact. The point around having confidence using the technology, we have commissioned a piece of work with Age Concern that is targeting adults, and we have had 300, 400 referrals into that service. And majority of people going into that service come back with confidence on how to use technology securely and safely. But a lot more work to be done from an exclusion perspective, but this is something, as we discussed in our digital strategy presentation, that we have a number of initiatives on. So a really good sort of story, and I think there's a lot of feedback for us to take back. Thank you.
Thank you. Thanks very much indeed, Asim. Good. So always important to ground ourselves in that patient story, the citizen's story at the start of the board. I'm now going to move on to the first section, which is leadership and operating context. The first of that is my report, which I'm very happy to take questions on, but I will take as read. There were just a few words I wanted to say, though, on the fact that we are in intervention for financial delivery and what that means, particularly in the context of today's agenda. Kevin will speak about it more later and provide more detail as we go through the board. We have, as board members and those that have followed our board meetings will be more than aware, a significant deficit plan agreed with NHS England, and we're not delivering as a system against that plan. Delivery is delivery, and if we can't deliver the spending we promised, we can't deliver the transformation we aspire to either. So I see this as an issue of developing a confidence across the system that we deliver what we say we're going to do, whether that is financial or whether it is clinical, whether it is quality, whether it is strategic. And we can use the support we're going to get as part of the intervention to develop and embed that culture of delivery, and that will help us to achieve our plans to reduce our deficit, but it will also provide a platform to deliver the vision for healthcare that we set out later in this agenda. The next few months will require immense vigilance from this board in scrutinising plans and challenging for greater delivery, but also in triangulating across performance and quality metrics to ensure that all bases are covered. It is well known that the most cost-effective services are the highest quality ones. But during a period of transition and pressure, it's all the more critical to focus strongly on quality and patient safety. And finally, the board must ensure that we maintain our commitment to the long-term transformation of services in line with our clinical vision. We're the system leaders around this table, and so we must lead the system in pursuing and delivering the plan that we set out later. That's the only way we will address the inequalities of care, improve the quality of care and the experience of patients, and also live within our means. My final point is that as chair, I need to ensure that under considerable pressure, people have the space and time to do what is needed. That will require focus and will mean that we need to be ruthless about keeping our eye on the ball and focusing on the key issues, particularly over the next few months. Thank you for that. Thank you for that. Are there any questions on my more normal report? No. In that case, I'd like to hand over to Kevin.
Good afternoon, everyone. Just a couple of comments on my report. Just to first of all follow on from the chair in terms of intervention. 39 out of 42 ICS systems are in the investigation and intervention programme of NHS England. We're now moving to a more formal stage of that. PricewaterhouseCoopers have been appointed to work with the system Their focus and our focus will be on improving the year end and looking at the 25-26 budget to make sure that that deficit is coming down significantly. Just to be really clear, we welcome Pricewaterhouse's joining us. We will work with them closely, and we see it as a real opportunity to get on top of the deficit and progress the many opportunities out there for reforming our system so we do things faster, better and smoother. The second thing I'd like to mention is the new hospital programme. Both Morecambe Bay Trust and Lancs Teaching have now acquired the sites, which are going to be subject to consultation. We have got a process to go through there, but this is a very significant milestone for our system. We haven't had the investments that many other systems have had, and now it's really becoming a real project going forward, and I think it's just worth noting that, Chair. I'm happy to answer any questions if people have them.
Thank you. Thank you, Kevin. Any questions for Kevin? No. Okay, so let's move into the body of the meeting, the Board Assurance Framework.
Thank you, Chair. So this paper presents an update on the controls, assurances and activity undertaken in Q2 and Q3 for the principal risks held on the BAF over that period. These risks are aligned to the delivery of our key priorities and actions that support achievement towards our 6 strategic objectives. Section 3 of the report provides a summary of executive and committee oversight of each of those risks over the period. And it also highlights where we've got one increase in a risk score relating to health inequalities, one risk that's proposed for closure that's relating to place, and just to note that the risk relating to the ICB and system financial plan has been fully reviewed and updated, and that's presented, and the highlights again are summarised in table 1 at section 3. Mitigating actions for each risk are aligned to the executive delivery plan that's referred to in the report at section 2. There are 2 risks highlighted that are held on the operational risk register, which are assessed at a score of 20 and therefore meet the criteria to highlight to the board. On a positive note, our internal audit phase 1 review of the assurance framework has concluded that the BAF has significantly improved since the previous review in 23-24. And just to highlight that following the outcome of the committee review that's referred to in the Chair's report, there will be a full realignment of the board assurance framework depending on the outcomes of those arrangements. Thank you.
Thank you, Deb. Questions on the board assurance framework? It's important. I know everyone knows this, but I'm going to state the obvious. Deb and her team are obviously responsible for the structure of the board assurance framework, but each of the areas of risk has an executive owner. So questions will be addressed to the executive owners, obviously. Sarah.
I just wanted to make a comment, if that's okay, Chair, on the 2 corporate risks that were highlighted, the operational risks that were highlighted in Section 4 relating to neurodevelopment pathways and SEND, just to formally inform Board that we were part of as a statutory partner, ourselves and Lancashire County Council had a SEND inspection just on the run up to Christmas. I can't share the outcome of that inspection with you at this stage, although the draft report has now been received. We are expecting the final report at the end of January, and I will bring that to Board with an action plan. But I think that risk is reflected in that SEND inspection.
Thank you. Yeah. Denise.
Just to follow up with a comment rather than a question, because relating to what Sarah has said, clearly as the local authorities are also the statutory partners for SEND, I think it's important we continue to work together. There are demand pressures everywhere, but as statutory partners, obviously, I think Blackpool have had their SEND inspection, Lancashire have had ours. Ours is due any time, so it is important that we continue to work together. These are, some of our most vulnerable young people, and I recognise the pressures right across the system, but I'm sure we will work together to look at what we can do to support.
Yes. Thank you. Andrew?
The overhaul that Deb had referred to in terms of the meeting financial targets risk, the issue with that at the moment is because of the intervention and inspection process, it will be a fast-moving thing, so we will need to continually highlight updates and changes in that as we go through and get into the rhythm with that process.
Yeah, no, absolutely. Thank you. Jim?
Thanks. Can I just ask why the reasons behind closing the risk 10 around places? Because it's still kind of an ongoing requirement for us to develop and to take that forward, and it is an underdeveloped area basically, so I don't know why that risk has been taken off or why it's proposed for closure.
So this was about how the risk was particularly written, Jim. So we wanted to be clear that with the pausing of the place deal, but the ongoing work to develop places continue, actually the frame of this particular risk, how it was written, we didn't feel that that was the most appropriate way, and we wanted to capture the risk in a different way about the development of place and not necessarily in relation to the delivery of the deal with regards to the delegation element, which was about delegating resources or money. So it's to be refreshed with something more appropriate based on our current circumstances, the emerging operating model for commissioning, which does have a place component, and where we are in relation to intervention.
So something will be coming back in?
An alternative risk,
okay.
Not this one.
Yeah.
And can I assume that will be for the next iteration of the... Great, excellent, thank you. Sakthi?
Thank you, Chair. Just looking at the Board Assurance Framework and the risks again, I noticed that the only risk that's actually going in the wrong direction is the duty to reduce health inequalities. And I know that there is a paper later on the agenda, and I just would like to highlight that we need to continue to maintain our focus on that, and also think about what will it take for that direction of the arrow to go flat and then go down at some stage.
I'm pleased you picked up on that one, because I would be interested to understand the logic for why that has actually increased, because it felt like times is tough, therefore we're assuming it's going to get worse, which I'm not sure is necessarily a contention I would agree with.
That's me.
It's you, David.
So the previous risks were set at 12 and it's been moved to 15. And I think, to be honest with you, that reflects, and certainly the population health team felt it reflected the current position that the population's in. Unfortunately, there are, and it is reflected in the kind of comments on page 45. Part of it is that it's sit outside health. Part of the challenge is sit outside health. There are real financial challenges to our population at present. So that's why we and I don't want to rehearse the agenda item we're coming to in a few minutes, but that's why we've had the focus at the board, and I think it may be a 15 now, but I would hope with the paper we have today and a further paper that's coming in March, we could be in a position where we can hope to reduce this. But I think it unfortunately reflects the pragmatism of how it is today.
Yeah, I mean, I just think we probably need just to reflect a little bit on this one. I mean, I completely get where David's coming from. The external environment is very challenging, and that is going to increase inequalities, but the risk is about what are we doing to deliver our statutory duty to reduce health inequalities. I can think of a number of initiatives now that we've taken as an ICB, for example, on admission avoidance. That actually improves the position as we can. Hypertension programme in primary care is very much focused on people in deprived wards, etc., etc. There's quite a lot of things we're doing that are changing the dial the other way, but I think you're right, the tide is coming at us. So it's but we can only do what we can do, can't we? We can't. So I think the risk is about what we're doing as an organisation rather than the general climate. I think you've got to recognise that. I just think we probably need to look at that a bit, Deb, don't we, and tease it through in terms of what's happening in the general climate, but what are we doing as an ICB and as a system to make a difference in a challenging environment?
I think that sounds sensible. Yes, Chris.
Thank you, Chair. I just wondered, it's just a reflection. So we've got LSCFT's Health Inequality Action Plan and strategy being signed off at Trust Board next month. All providers will have something similar, and I wonder whether there's a piece of work to do to overlap what providers are doing, both NHS and non-NHS, with the overarching work of the ICB, and see where we could, that might. I'm just looking at some of the gaps and some of the assurances. I think if you were to overlay with providers, there'd probably be more. I think we would reduce maybe some of the gaps in that space. Just thinking, I know that Abigail, who's a SIMS counterpart in our trust, is looking at how, when we renew our Wi-Fi for certain of our premises, actually can we just extend it into some of our communities at no extra cost to the organisation, but would then give some areas that will be quite deprived and might not have access to Wi-Fi connection, for example, for health or whatever. I think there's just maybe some overlap that we could do there.
That's very helpful discussion. What I propose then is to pick up on David's point about bringing a paper back. When that paper comes back, I think we'd like to have a reassessment of the risk score, but having also done what Chris suggests, which is to overlay some of the work that's being done in providers, so we make the benefit. Sakthi, you look like you want to come back in
I
again.
would just add and partners, because
Yes,
health
and
inequalities
partners.
cannot be addressed by just the NHS, even
no.
if you take providers and commissioners together.
Okay, there's an action. Great, thank you very much indeed. Any other questions on the board assurance framework? No, thank you very much indeed. No, okay, excellent. So now, next section, developing the system and the strategy. We have the paper on improving health and care in Lancashire and South Cumbria, our clinical vision, which I'm delighted to ask David to present.
Okay, thank you. There's a narrative and then there's some slides, and I was going to refer to the slides in many respects, and conscious of your comment about let's not go through it in detail, I was going to pick out a few highlights by way of context. First of all, the national context, which is on slide 2. You'll be aware that we're awaiting a national 10-year plan, but already we understand there will be a shift from acute care to primary care settings for healthcare, a shift from treatment to prevention, and a shift from analogue to digital, which is interesting because I think our meeting reflects much of that already. Slide 3 refers to a blueprint that has been developed for the acute sector of care. It doesn't include mental health. And there are a number of other strategies in the new hospital programme which are all running together and hold interdependencies. From that blueprint, we've identified a number of commissioning intentions which are reflected in slide 5, which have been shared with trust chairs and chief executives, and shouldn't be a surprise to them. Following those discussions, there was, as you can see on slide 6, an agreement about a narrative which is in the pack. There was a proposal for a 5-year roadmap called LSC 2030, as well as a review of clinical leadership. And as you can see through the next few slides, there was a workshop for LSC 2030 in November on slide 9, and slide 10 highlights the priorities which are proposed for the next 3 months, which is about getting ready for April 2025. The first one is around ensuring that we can identify patients towards the end of their life or particularly are frail, so that we can have advanced care plans for those patients, supporting patients at Blackpool in particular, where there are challenges around the oncology and stroke pathways, to consider developing a locally enhanced service for primary care, so we ensure there's a consistent offer from primary care and to reduce the number of admissions, and finally further development of a model where we would try and provide rehabilitation services in the community rather than in a hospital setting. There we are. Thank you.
Thank you, David. This is a really significant piece of work, and we've had a number of opportunities to see this as it's developed. But are there questions or thoughts around this? It will not happen overnight, and it will require an enormous amount of engagement, processes, work, decision making, and so on and so forth. But it is quite a significant moment that we have this piece for one part of our system, the acute part of our system, and it needs, as David said, to tie into to all the other parts of the system, both NHS and non-NHS. Aaron.
Thank you, Chair. Really supportive of the piece of work, and I think we'd said in the sessions pre-Christmas, the vision and the roadmap that's being developed makes it easier then to tell the stories with colleagues and patients about where we want to take the service in this next phase. We also said there were a couple of things that we wanted to revisit. One was a real understanding of the what, by, when. So we're going to be under pressure this quarter to be really articulate about the impact of these priorities in 25-26. So we've agreed, haven't we, to do fewer but more impactful kind of programs of work to build momentum and a bit of confidence. So given that we're about to approve, I think, 2 or 3 areas of priority, we now need to move quickly into how do we get delivery plans for those that we can approve before the start of the financial year. But the second piece that we talked about was, do we have a good enough understanding of what would stop us being successful in these areas? And we highlighted 1 or 2 particular concerns. One was around governance and decision making. So I see there's a point in the slide which I don't agree with, which says the projects are largely delivered by one trust. I think if we're going to be successful, the provider collaborative, even if services are held in one organisation, there has to be a cross-provider leadership team that develops and takes the improvements forward if we're going to build this cohort and community of clinical leadership. It's a really important point I think we need to come back to. And the second is the financial imperative and the risks that get presented in change. I've said before, I think when we start to talk about programmes that get stuck, I use the word stuckness, I appreciate it's not in the English language, but when the risks get presented or the finances get presented with an impact in one area, it prevents boards from committing and delivering in the way that we would want them to. So I think what we agreed last time is some sort of risk share or financial framework this quarter that means when we make these decisions, there's less stuckness as we move into delivery. So really supportive of the piece of work. I think there's just 2 or 3 things that we now need to move into some practical approval in this quarter, Chair.
Who wants to come back on that?
Well, I'm very happy to kind of say to Aaron, I would agree with you. We have agreed to focus on a few areas. I think particularly where we are now looking at the one LSC model for pathology, I think we are now getting into that granular detail, which is really important. And Craig and I had a meeting with Silas this week about who's going to do what by when, so we can truly be in that position. But as you've described, it may be led by one trust, but it will have an impact across the whole system. And in fact, for the pathology work, it will reach out into primary care as well.
Sakthi, are we bottomed that?
Chair, I think we need to come back to the governance and the financial framework pieces. I get the connection with colleagues on kind of coordinating where there has a cross-system impact. I just think there's some gritty structural things we need to bottom this quarter if it's going to be successful from April.
Yes, and I think in the context of, I'm looking for Craig. There's Craig, yes. So in the context of commission, this is the commissioning intentions framework that we need to be able to support us with that for this year, I think, isn't it? We've got there's a balance, isn't there, between given the turnaround we're in, we're not going to be setting up a new strategic powerhouse because we're quite busy, and yet we've got to find some way of driving through the 2 or 3 things that we want to do next year. And I think I would suggest that we take that offline, but that we report back to the next board. Yeah, good. Debbie. Sorry, no, actually I had Sakthi first and then Debbie.
Thank you, Chair. Sorry, Debbie. It's slide 19. It's really good that we've got a vision and the sense of priorities coming out for the next 3 months. I'm just curious about, given everything that's been said on this so far, how realistic is it that we're actually going to see delivery of the priorities for the next 3 months on slide 19? In particular, mobilizing the deteriorating segment, focusing on palliative care in the last 1,000 days. I'm not quite sure how that actually relates to actual delivery in the next 3 months and what would count as success for the board to be assured that it's actually going to happen in the clinical strategy. And the second point I was going to raise was the public narrative. What is the public narrative behind this? It's not out there, and the main narrative is about demand. And if we want to get public engaged in, especially palliative care, which is quite a sensitive area of work that most people will want to engage with, given the national narrative about end-of-life care as well, there's something about the public narrative that as a group need to think about. Thank you.
Thank you, Sakthi. David.
So going back in again, the priorities for the next 3 months are the ones that are going to be worked up. I mean, it's not as if they're going to start tomorrow, unfortunately. So I think the proposal is that there will be plans for these areas of work, which can then come back so that we can understand when they're going to start. But I would hope for many of them they will be starting from the 1st of April of this year. But you can't just say we're going to do X and suddenly it's going to happen. I think, I'm sure Neil may want to come in at some point about public engagement. There is a huge amount of public engagement that takes place. And we have worked, I mean, people do want to work and understand how they can proactively manage their health care. And I think that's what we're trying to do, is help the population understand what they can do to help themselves, to ideally avoid admission to hospital, attendance at EDs, use digital technology which may be available to them, for example 111, to ensure they can get the healthcare advice they need without necessarily having to end up at a hospital setting.
Yeah, thank you, David. I can see you, Julie, but I'd like to bring Neil in because I know we do a huge amount of public engagement. Neil, why don't you, I think you really ought to be sitting around the board table, to be fair.
Sorry, if I'm okay to just mention on some of the public narrative, I think that's probably really important. So in the paper there is some of that idea of that vision, some of the challenges and some of the priorities. And I think some of that conversation is what we've been having with the public over the last number of months. So particularly between September and December, we held a series of public engagement events, a series of external engagement with lots of different community groups, and some work around perception as well. So we have a good understanding of what our public's views are, and some of that has helped to shape some of the work that's in front of you. I do think as some of these pieces of work develop and as the roadmap work develops, it's really important that we can then start to describe what does this mean for some of those different areas, and really involve people in the right ways, which we've started to demonstrate through certainly some of the reports that we've published as an organisation for our committee, the Public Involvement Engagement Advisory Committee. So absolutely at the heart of this actually does need to be that really strong engagement, involvement, public voice, and start to actually understand, we start to shift some of the experience. I would say some of the patient story we heard at the beginning of the board is really key. So that's already starting to kind of influence some of what we're hearing from people and needs to shape some of the transformation work that we need to do.
Thank you, Neil. So I've got Debbie, who's been waiting a long time, and then I've got Julie. Anyone else? No, Debbie, then Julie.
Thanks, Chair. And I think Neil's response and Sakthi's question actually preempted me, because that's the point that I was kind of going to make, which was just to link back to the published report. So the report today picks up on those themes and the direct feedback that we've had both through the programme of activity in the last quarter, but also the activity that we've been doing on an ongoing basis, and also what we've heard through partners like Health Watch. So it's all been triangulated, it's all been brought together, and in the AAA that's received from PIAT later today, the action as a result of it was to get assurance that that learning is embedded throughout all of the recovery programme, all of the commissioning, and that I think is the assurance point really. So there's been an excellent start, there's assurance through the committee, but there is that ongoing oversight that's needed really to demonstrate and then loop back to the public that we've heard we either are doing, or if we're not doing, why we're not doing and what difference we're making as a result of the feedback.
Thank you, very helpful, thank you very much. And Julie?
Thanks, Chair. It was just around patient narrative and deconflicting some of the language that we use. Following COVID, there's definitely been a fear in the patient population when you start to talk about do not resuscitates and de-escalating access to urgent care if you're deemed to have a label of being end of life or frail. So I think we just need to acknowledge that when we're putting that ourselves into the same chapter, that we need to really explain to the public that we're not mixing those issues up, just so we don't end up with a problem.
Thank you, very helpful indeed. I'm going to bring Kevin in last.
Yeah, look, I think as you said right at the beginning, it's a very significant report, this, and it's the start of a journey, isn't it? So I think we've got to bear that in mind. I guess the starting point is we have a system that hasn't really changed for quite some time. We have a major postcode lottery within that in terms of, we talked about inequalities earlier, and we're going to be talking about them again soon. But if you look at patient safety, quality and value for money, there's actually, interestingly, quite a strong correlation between the three, but a huge variation across our system and across our specialties. If you did this in a classical way, you might do a big project and design, and you get lost in it, and it becomes quite difficult to figure out what you're practically going to do differently. So what we've tried to do this, to come back to Sakti's question earlier, is a sort of planned incrementalism. Keep it simple, stupid, you know, the KISS principle. Pick a few areas, learn by doing, and then figure out what we need to come back to Aaron's question about governance, what we might need to do different in terms of governance, and what we might need to do different in terms of enabling us to really deliver what we promise here and do that execution side well. So I think this is probably something we do need to come back to on a regular basis, and certainly when we sign off the commissioning intentions in March formally, I think this is something we do probably need to take stock of and then keep coming back again. But it is that planned incrementalism. Let's not make it too big. The topics that we've chosen are right bang in the middle of the recovery and transformation agenda. To cover the end of life, we know that there are quite a lot of planned deaths in hospital that could be a much better experience for the patient if we do it in a home environment or with specialist providers, and actually it frees up the hospital to focus on what they should be doing, etc. So I mean, there are real opportunities here to make a difference, but let's not try and do everything. Pick a few areas, do them well, learn as we go through that process so that we can pick up the pace and do things really well.
Thank you, that's a good summary. So this will come back in March alongside the commissioning intentions, but I think you're right, Kevin. I think the board will want to see progress on this at most board meetings, I think. Thank you. Okay, so the next item we have now is reducing health inequalities. So still with you, David.
Okay, so as promised, here it comes. So first of all, to say, by way of background, Lancashire and South Cumbria is home to some of the most severe inequalities in the country, and in fact Blackpool has more inequality than anywhere else in the United Kingdom now. Okay, Blackpool overtook Glasgow. So there's undoubtedly, this is a significant part of work for the Integrated Care Board, and it was great that we had a workshop approximately 1 month ago with the board where the population team went through kind of some of the challenges that we currently have. This paper really heralds a paper that's due to come back in March and just sets out some directions of travel. If you look in section 3, there are in 3.2 some proposals about some targets that we could aspire to. Perhaps they could be regarded as audacious goals. And in fact, but if we're going to deliver any of this, the most important thing is that we do need to work at place. We need to work with our partners, as Sakthi has described already, and we need to work with the third sector. This is not just the ICB doing its work alone, and many of the interventions that are required sit outside healthcare and sit, for example, in housing and elsewhere in education. And within there, it highlights the leadership as well. We've had over 150 leaders go through the Population Health Academy. And it highlights that maybe we need to look at the total resource spent on inequalities and look at and bring something back as a proposal for how we could look at how that could be increased in the future, hoping that we move to a much more stable financial position. So it just highlights the proposals for a paper that will come back in March. Thank you.
Thank you very much, David. So we had a good session as a board on this, didn't we? And my take out of that session was, which I think is reflected in this paper, is that we were going to try and pick some specifics for next year, and that we had other aspirations that we wanted to work up. But next month we will get the specifics for next year, will we? The metrics that we're going to measure ourselves against for next year.
They'll come back in the March.
In
paper.
March, in the next, yeah, excellent. Okay, fine. Thoughts? Sakthi?
Thank you, Chair. It's a really good piece of work. There's been a lot of engagement from members of the board and wider partners, really supporting, working in partnership with David and the population health team from the Director of Public Health. Just linking it back to the risk discussion we've just had earlier on, we probably need to, and again speaking to the point that Kevin was raising earlier, it's real opportunity to be as specific as we can and just keep it simple as we can, because we could lose ourselves in highly technical analysis and trends and so on, but actually we can only do a few things realistically next financial year. So it's a real opportunity that we're working together in finessing and shaping this. The second thing I really want to highlight on this one is the idea of tracking the spend on prevention. It's mentioned here, it's in Hewitt's report and it's in Darcy's report and so on. We mustn't see this as a specific part somewhere in one team within the ICB or within any organisation that matters. But we should see it as a whole budget for the ICB, and that 1% is for the whole budget of the system, not the 1% of the population health team's budget, for example. That would be a really small drop in the ocean that we should not sort of pat ourselves on the back thinking we've increased the population health budget by 1% and that's job done. I just want to make that point because there's an issue of understanding what's being said in the national reports, and we need to translate that into practice as a system.
That's very helpful, actually, because I think given the financial pressures we're after, carving out a sum of money that might go on administrative type of things is not the most attractive option. But actually starting to say that if every penny we spend, 1% of it should be on prevention is a much more compelling narrative and compelling thing to do, isn't it? Yeah. So lots of hands suddenly. Aaron and then Sarah.
Thank you, Chair. So I'd argue this is a more important document than the acute configuration piece. I think it's as important as a signal of intent as a board. So I'll be guided by others who will decide that those three kind of areas of focus are the right ones, and I know there'll be something coming back to the board with an impact assessment or a viability assessment. But if we can get to a position where we understand what that would mean for capacity, demand and provision of care in the provider sector if these things are to be successful, we need to be able to map that out in our recovery and transformation programmes. And it would help with Sakthi's point, which I really agree with. This is everyone's business. So if we can get engagement from all providers that we need to put our own resources, our own leadership and our own way of delivering connections at place into these 3 areas of focus, I suspect we'll see a material shift in demand and capacity very quickly. But we don't look at it in the same way as we do with elective recovery or A&E performance, etc. So I think we need to systematise the performance management, for want of a better phrase, as how this gets managed. The point that you raised, Chair, about the whole budget, for me, this again sits in the difficult box. How do you create a left shift investment in these areas, knowing that all of your budgets are overspent at the moment and locked into certain partners? If we can agree, this is to Kevin's point, this 3 to 5 year longer term health inequalities reduction and prevention strategy, we would want some permission to operate, some flexibility of where deficit sits and how we operate our financial framework. So I'm back to the same point I was mentioning about this financial framework piece underpinning some of the strategic clinical changes we need to make. So it's a critical piece of work, Chair, I think, that needs to come back.
Do you want to come back on that, David?
No, I thought it was a very helpful comment, Aaron. Thank you so very much.
Sarah? Sorry, actually, I will bring Asim in because I'm sure he's going to come back on the point about measurement, and then I'll bring you in, Sarah.
Thanks, Chair. So yeah, I think a couple of points, and I think tying back to Sakti's comment around the risk, and until we have measures and outcomes, I think it's very hard to describe a risk. And if you look at the risk, it's more around capacity, resources, and gaps in the ICB team. So I think some of that we need to look at. And I think this will help us be very clear whether we are making an impact on improvement around health inequalities. And because we don't have that systemized performance, it's very difficult to see that. So I'm very welcoming of seeing the metrics and how do we then include that in the performance report. And all of this has to triangulate. So the clinical strategy, and we heard the healthy life expectancy. In some of our areas, that's 10 years less than the national population. These people will have more long-term conditions, and these are the people that are going into A&E and then ending up in our beds. So this is why the demand is being created. So it cannot be looked at in isolation. So I think systemizing it, understanding the impact of our intervention, I think will lend itself to a better board-level conversation. Thank you.
Sarah?
Yeah, thanks, Chair. I wanted to really build on the point Sakti made, so I really welcome the paper. It's a really good paper, and we did have a really excellent board discussion, but I think development session on this, but I think we did agree that probably it was about focusing on a few really key areas and doing them really well. And I suppose my plea is to make sure we connect this with areas of work that are already working on this agenda, but you could connect, so for example, we know despite years of national drive through the LEADER programme that we're not turning the dial on mortality and morbidity in people living with a learning disability. So they are one of our most vulnerable groups where they have got a real health inequality. Similar, we touched on children very briefly before when we talked about SEND. We know children who have got neurodiversity or care leavers are amongst some of, again, our groups who are some of our most vulnerable, and also really, even within those communities where we've got health inequalities, have an even greater impact on health inequalities. So I suppose my plea was, can we make sure, David, that the team are connecting with other teams who may already be focusing on areas of work, so that if we do agree on, 1 or 2 or 3 areas as a system, that it's an area that the whole system, i.e. partners, can also really support us with. Thank you.
Thank you, Sarah. David?
So, Sarah, of course we will do that, okay? Very important. And in fact, of the 3 measures in 3.2, one of them does refer to disadvantaged children. By chance, tomorrow there's another meeting with our Directors of Public Health from across the system as well, and I think this paper will be something useful for us to discuss further, because we need to ensure it's not just ICB teams, but it's partners across the system feel that they have a say on any proposed targets we might choose. Thank you.
Vicky, did you want to come in?
Thank you, Chair. And Sarah's actually already made the point that I was going to make. It was also a plea from me. Clearly, being based in Blackpool, this is a topic that's really close to my heart. So like Sarah, there was a bit of a plea from myself to consider those vulnerable groups of children, particularly care leavers. You know, we know there's so much data about those groups in terms of the future outcomes. But I was also sitting thinking about the earlier comment about the direction of travel on health inequalities. Now, I don't profess to be any expert on this at all, but I was thinking about what I know particularly about Blackpool and about our population there. We know, and I'm not suggesting that poverty and deprivation is the whole story here. We know there is most definitely a correlation. We see it in lots of other data, and we know, and I think Saxy touched on that sort of real complexity that we're dealing with here. But I was thinking that actually a lot of if I think of the community in Blackpool, a lot of those adults there, you know, they're often the people that are most in need of help, but may not be the people that come forward for that help. So there was something that I was thinking about, that in developing this, how do we reach into communities that are often quite marginalised and perhaps not willing to come forward? Is there something around co-production and asking them what will make the difference? Why is it going in the wrong direction? And is it something about how this is approached, tackled, how we pull that together? I don't know. It's just a thought, and I was thinking about it as we got into the discussion. Thank you.
Thank you. And that was very much something that came across in the seminar we had, wasn't it? That is, and I think that is being built into the strategy. Am I right, David?
It is, and you're quite right. The fact is, if you take a rather kind of helicopter view, you're going to get you won't be able to identify some of those communities where there is true significant deprivation and things need to be done. And what has been found is that you really need to get to quite a granular level. So not just in Blackpool, but also in Barrow, we've often got down to, it's a couple of streets where, in fact, this is where the issues are. And in fact, we've found out that it's not about sending out a letter saying, please come along. You have to go and knock on the door. So the processes and the how is being built up and aren't being understood. But you're right, we just need to get to that granular level when we come to doing this work. And it has to be done at a very local level.
Thank you very much indeed. So it's great to have this. Look forward to it coming back next board meeting. And I think I'm hearing the board endorse the intention to develop high-level goals that are achievable and that are pragmatic, that we can make some progress on next year, but also the work to develop a phased multi-year delivery plan, which I think picks up on your point about the financial framework, Aaron, which is very important, and will also pick up, I think, on the baseline of the prevention spend and how we reflect and then monitor that across the system. Excellent, good, thank you. So we'll look forward to seeing that next board meeting. Next item, system recovery, investigation and intervention. Kevin.
Thanks, Chair. Just first of all, make some comments on the wider system. So we saw a significant deterioration in our financial position in October and November. I think there were really two core reasons for that. The first was we had across the system back-ended efficiency savings programs, which we started to run off plan on. We weren't delivering them on time to budget. And then the second area was we had agreed with PA Consulting as part of an earlier stage of to have a firebreak program, effectively looking at discretionary spend, vacancies and things like that to really tighten our belts. And again, they have slipped and have not delivered to time and to the budget there. So that really led to really a big off-plan figure. Not all trusts are the same. 3 trusts account for about 80% of the off-plan figure. Those 3 trusts are in the process of one has already appointed a turnaround team and 2 are going through the process of appointing turnaround teams. And clearly, as part of the intervention with PricewaterhouseCoopers, a key thing is to get on top of the 25/6 planning round. We still haven't got the guidance yet from NHS England. We don't expect to receive it until the end of February, which is a little frustrating. But there's quite a lot we can do without that guidance, and we are definitely very much focused on that. For the ICB itself, I guess there are 2 areas that we are focused on. One is all age continuing care, because it's such a big part of our budget outside of mental health and acutes. This is the biggest budget in our area, and we are also the delivery lead on that as well. So it's a sort of slightly different position to most of the other areas of the ICB where the commissioner. Here we deliver the service as well with partners. So that's a big area. We have, with Sarah and colleagues, we have brought in a turnaround team into that area to work with Jane Brennan and Raki, who are the leads in that space. And that's going quite well at the moment. The second area is commissioning. This is particularly about 25-26. As an ICB in the current round of savings, it's very much grip and control. It's looking at grants we get from NHS England and holding back on some of those. Going forward, next year needs to be much more around commissioning services, both for the ICB, it's our own budgets, but also to help the providers, to give them the head cover to do some of the difficult things, because as a system we are spending quite a lot more than we get in income, and you can't do all of that through efficiency. You can do quite a lot, but you've got to make some difficult decisions to not provide some services or to change service levels as well. So the commissioning is really very important part of that. So I hope that gives you a flavour, Chair, and very happy to answer any questions.
Thank you. Thank you, Kevin. Any questions? Yes, I've got Aaron and then... Sorry, I've just had a complete blank. Aaron first.
Thank you, Chair. So I think it's important to recognise, I guess, the scale of the challenge that we've got as a system, and then what the likely decisions are that we're going to have to make to bring that back. So this isn't pushing harder for CIPs or getting the extra bit of productivity out. This is a wholesale restructure, I think, of the health and care services that we provide, and you can see in 2 of the papers today, the acute configuration and the population health, we're starting to build a narrative now that shows how we will get there. The feedback, I suspect, from the centre is a bit late, and we've let ourselves drift out too much now, and we've got a mountain to climb. From a provider perspective, we've taken a couple of actions as a collaborative board through November, December. There's an honest reflection of the approach that we've taken separately as trusts in the way that you approach financial recovery, cost improvements, budgetary management. And we use the phrase quite a bit, the best of the system to the rest of the system. And it's obvious that there are 1 or 2 organisations that are doing it really well. And it's having an impact on the ability then to manage cost control and deliver some improvement. So we've made a commitment that all trusts will follow the same protocol around planning, budget management and CIP delivery heading into next year. Some really good support being supplied by Simon Worthington, very experienced CFO in the system who's working with us on that. And the second part is having a really honest conversation in February, March, when we see draft plans with some proper check and challenge and peer review of each other's plans as we head into this next phase. Again, it doesn't shift the dial on delivery, but it does improve the accountability, I think, as we move more into the collaborative, having a bit more teeth, not just on overseeing transformation programs, but how we manage the collective collaborative in terms of core delivery. So just some additional levels of reassurance, Chair, on how the collaborative's approaching this quarter's planning.
Thank you. Just before I come to Denise, the check and challenge work, that happens before you go to boards, does it?
It will be. So in terms of the sequence of events, we're now having to put first draft plans in, Chair, as you'll be aware, next Wednesday. Yeah. So it moves us out of kilter a little bit on having the time to do that, but through February and March, what we'll do before boards sign off plans, they will go through a peer check and challenge in the collaborative joint committee essentially.
Got you.
Before finalising plans in March.
Got you. But it's not in any way diluting the role of the board.
Not at all, no.
Fine. Denise.
Yeah, I fully appreciate the financial pressures the system is under, but a plea really from partners that we work collaboratively on some of this where we can, because some of the decisions that get taken can have consequences for partners, and we've seen that before, and where it isn't done collaboratively either way, it can really impact on relationships and the work that we've talked about earlier in this, about moving forward with the 2030 roadmap, addressing inequalities, addressing the pressures right across the system. I think Aaron's just said it, this is about the health and care system. It's not just about the NHS side of it, and we recognise in terms of those financial pressures some of this we will have to work together on. So just a plea for continuing a collaborative approach in this.
Thank you, Denise. I take that as an offer as well as a plea, so that's really helpful. Thank you. Any other thoughts? Yes, Saxi.
Yeah, just building on the point, but from a public perspective, it is not going to be the case that we can just reduce costs without changes in the service levels, like Kevin was mentioning before. The more proactive we are in specifically engaging with our communities about the changes, the better we will be able to take people along with us. There's already been one or two examples where the people are feeling they've just dropped decisions, and it's creating perhaps an element of surprise that we could do without, really, with our communities. So that would be my suggestion, that we consider it in its totality, be very specific. We've been very good in engaging the public and carrying them with us in terms of the broad vision and all of that, but this is specifics, and people would like to know the details.
Yeah, I think that's a very fair point, and I think the communication of what this means is critical. And I can see Neil nodding. I mean, a lot of the things that we talked about in terms of the acute clinical reconfiguration work are things that our patients are saying that they want to happen, and they will also. They are what people want to happen is often a much cheaper way of doing things. Sometimes we overcomplicate by providing things in old-fashioned ways that don't meet patient need and overcost. But the communication aspect is really important. Kevin.
Perhaps try and end on a more positive, upbeat. We talk about challenges and problems, but actually loads and loads of opportunities here. If you take the clinical reconfiguration report we talked about earlier, big variations in terms of quality and value for money across our specialties. Well, if they can do it really well in Hospital X, they can do it well in Hospital Y too, can't they? We've got far too many frail elderly patients in our hospitals, and that could have been avoided, so we need to really focus on making sure we do that. And we've got far too many old-fashioned support services on old technology, and in some cases no technology, and we can change that by bringing it together and modernising it. And by the way, we're on the journey on all of these fronts. So I think we've got to look at the the glass half full, and really focus on the opportunities here, and use this opportunity with Pricewaterhouse to get some support from them, so that we've got the focus with NHS England to make progress rapidly.
Absolutely. I go back to what I said at the beginning. This is about delivery. So there is a real opportunity here to sharpen our game as a system, and then we'll be unstoppable. Great, excellent, thank you. Performance overview. So we've got reporting from committees here. I'm going to start with Debbie for Public Involvement and Engagement Advisory Committee. We've already touched on this, but
Thanks, Emma. The minutes and also the AAA for the last PIAC meeting are provided, which was 18th of December. So we've already touched, there were no alerts to bring to the board's attention, but there were a few things that I was just going to mention just really because there's opportunity. We've already talked about under advised the recent programme of activity that's drawn together a 3-month intensive engagement and involvement process, but also the learning over the past 18 months into one place and distilled it down. And then, as was reflected in Kevin's report and the discussion that we've had, the action is for that to be embedded and it to be really clear about what a difference that's made in terms of the commissioning intentions, key strategies like the clinical vision, and to be able to demonstrate and feed that back to the public so that they can see that we've listened and we're evidencing that. Under Assure, it's worth noting that there was an update received, an assurance given around the engagement programme in priority wards, so it picks up on the health inequalities discussion that we've had previous. So the committee took a close look at the work that had been carried out, both by the ICB itself but also in partnership or led by others, because it's back to place being important and other partners being able to contribute learning rather than us actually duplicating work. So again, the report distilled that and brought it together. And the ask of the committee was that that really continues and is able to influence the strategies, but also supports that refined approach to health inequality, so that we can see in all the activity that we do, we're engaging with those who are hardest to reach or furthest away from services, and we're being proactive around that to be able to bring those voices to the table and shape services. The other thing, just to quickly mention, under Shaping Care Together and also New Hospitals Programme, it's just to mention that we received an update and also assurance around those 2 areas of statutory consultation around service transformation. So I won't go into detail, but it was just to assure the board that we have looked at that and we've received an update and we were able to offer feedback and advice to support that moving forward, which in the next few months will be critical, obviously, for New Hospitals Programme, given the engagement that's being launched around the sites.
Thanks, Debbie. Any questions for Debbie? No? Okay, in which case I will move to stay with Debbie for Primary Care Commissioning Committee.
Thanks, Chair. So there's a summary of the 25th of November and the 20th of December Primary Care Commissioning Committee meetings. Don't propose going through any of those. They were quite sort of straightforward and the summaries provided, but happy to take any questions around the decisions that were taken.
Questions? No, thank you. Sheena, Quality Committee.
So we've got 2 AAA reports for the Quality Committee. One is dated the 20th of November and the second one is dated the 18th. So I'm going to take those in 2 separate bits, and I'm going to assume that people have read the reports. I'm just going to pick out from the alerts particularly, and the first of those is, as was said, was the 20th of November. So the alerts I just wanted to bring people's attention to was around maternity, and the local maternity and neonatal system has oversight of this and has alerted us in the Quality Committee, which we're clearly seeking to understand even further, is a cluster of neonatal deaths at one trust, and to ascertain whether there's any cause for concern. So we have had some report back on that, and we are seeking a further assurance and update in December. If there is anything further we need to alert to the board, we'll be doing that in our January report. In relation to patient safety, there's clearly a lot of focus on this in relation to the large demand of people needing urgent and emergency care, and the way that the response is made now in terms of the way that service is delivered is through a lot of pressure on emergency departments, and so as part of the kind of requirement to get some assurance on that, the teams have now started to visit our AED departments to understand how that work's going and that quality visits are taking place. That's done very much with trusts as opposed to trusts, just to understand what's working well and what could work even better. And I think taking Aaron's point is it's that importance about learning across as well for the different providers and taking that learning across there. The third area I wanted to report, and you mentioned this in your opening remarks, Chair, we have had a question from
a member of the public. So the Quality Committee were alerted to the ongoing risk regarding a lack of, so this was the item that the Quality Committee were considering, was around alerted to the ongoing risk, lack of 24/7 thrombolectomy service at Lancashire teaching hospitals. And whilst we had some reassurance that there was recently was received of no recent reported serious harm, this remains an ongoing concern. And as I said, we have received a question from a member of the public relating to this, and we will respond with a written reply. And then the fourth area I just wanted to mention was around histopathology, that is about, and we have reported this earlier to the board, about a backlog in histopathology reporting, and the committee is seeking further reassurance on that. I'll take us swiftly, if that's okay, Chair, rather than pausing for any questions, on to the meeting of the 18th of December. And we've already mentioned today around Children and Young People Services, and in particular SEND. And we wanted to just alert the board to the continuing risks that we've got in waiting times there. The board will be aware that when we've talked about this previously, we've talked about looking at short-term ways of addressing this, but I think it plays really to what Sarah said before around need to look as a system about how we respond even more effectively to meeting the needs of children and young people, and think of the whole pathway and that early intervention, prevention, advice to parents and families, as well as any input that people might need going forward. The other two areas around dysphagia and our waits for occupational therapy. The other area we've already mentioned was around histopathology, and that update coming back in January, and work that is ongoing with primary care to help support them in implementing the patient safety improvement framework. But the item we wanted to bring to the board was the fact that in the national contract for primary care, that isn't yet specified. So we're hoping that we'll be able to put some influence further on how we can, again, support primary care in, I think, it's a really important way of actually ensuring that people are able to identify risks and in terms of clinical delivery and be able to respond to those positively. So that's all I wanted to update the committee with. Thank you.
Quite a heavy update. Jim.
Thank you, Chairman. It is a heavy update. It was a very good update.
Yeah.
So thank you for all this information. It's really helpful. I guess, you know, when you kind of reflect how many things you're mentioning, including things like we have like never events, 2 a week never events, when by the definition they're not supposed to happen. There's 2 a week happening, which is quite scary. How assured can we be that there are systems in place to address all these issues within the organisations? From a commissioning perspective, we need to make sure that the issues that you're highlighting here are being picked up and dealt with.
I'll start and then I'll hand you over to Sarah, and I see Aaron also wants to come in. So I think it's really important that in terms of just understanding how the work of our quality committee operates. So we are very much seeking assurance from trusts around both the way that they understand patient safety, effectiveness and experience, and what we do is look across that, and then Sarah's team work with trusts about understanding what are the understanding why the risks are coming forward, how they're being mitigated, but most importantly is tracking over time the impact of work that's being undertaken. And I think as we move forward and think about the work of the IAGs in particular, that's where we kind of really need to look at that assurance. But Sarah's team really do work very diligently to both understand what's going on in terms of the quality of care that's delivered for our residents, but also about, more importantly, how do we make improvement. So over to you, Sarah. Thank you.
Yeah, thanks, Chair. I will just comment, and thanks for the question, Jim. It's a really pertinent question. I suppose the first thing is to remind us really that as the commissioners of the system, we also have a duty around oversight of our commissioned services in terms of quality. So really that's what Quality Committee does. That's where we take our summaries of the core areas that we have those statutory responsibilities for. We take the reporting. So in a way, when you're seeing it here, you are seeing a lot because you're seeing a summary of a much larger agenda. But I think a few things just to try and give you the assurance you're looking for, Jim. So the team, we have a dedicated quality team, patient safety dedicated as well. They work really closely with particularly our 5 large NHS trusts, but also many of our smaller providers and primary care quality. So I've got a member of my team sits on all of our quality committees in our trust. I think that's really innovative, actually. That didn't happen in a previous system I was in. So there's already, we get direct insight into the sub-board committees of each of our main providers and what they're doing in terms of it. So that gives us a level of assurance because we're seeing the papers, we see what goes up to board, and we're seeing the challenge from the NEDs in our large commission providers in terms of quality. We also have a member of the team that sits on the mortality review meetings in each of our large providers. So again, we're right in there, we see all the papers. So a level of our how do I assure quality committee that our trust boards are doing what they should do. A level of that is we review the board papers, we're sitting on the quality committees and we're sense checking that, but also the teams are working alongside the teams in the trust. So when there's a never event, our teams are aware of it as well as the trust teams, and we often work together in terms of the reporting and the learning. I'll just come back on the comment on never events because that is quite a lot. Nationally, we are seeing a rise in never events. So it's a really relevant question. But it's not just Lancashire and South Cumbria. We know that nationally there's been an increase in reporting of never events. So I think, and that probably reflects operationally where the NHS is, particularly at this time of year. Just a couple of other things in terms of assurance. So as well as reports back to board, and you can see where we're not reassured at Quality Committee, we ask for more reports to come back until we get that assurance. We have the IAGs, so, and I know they're changing a little bit at the moment for PwC, but we can take things into IAG. Over the last 2 years, some of our trusts have been under a system improvement board with NHS England, so we will also take any ongoing quality concerns through the system improvement board. If we're really concerned and not reassured, we work closely with region as well. Things will then go up to a regional quality surveillance group. So there is a regional surveillance meeting every month where any trusts across the North West that are of concern to either regional colleagues or the commissioners in the ICBs, we will take those themes there. And the last thing I would say is in the December AAA, you'll see there's both an advise and an assure. We have assessed ourselves against the National Quality Board guidance that kind of guides us on how we should be doing this, and we've self-assessed reasonably well, but we've also developed a quality governance framework for our ICB that gave Quality Committee quite a lot of assurance at the last meeting about how we're doing all of this. And again, I'm happy to share that document with any board members who want to see our specific quality governance framework, because we've tried to describe there how we do the assurance and how we oversee the trusts. Oh, and the last thing I'd say is we've also got quality indicators in the contracts. So we still have the old Schedule 6, is it, or 4, but the schedules in the contract that all of our main NHS providers have, they have to submit to us evidence that they're meeting the quality KPIs and some of the national standards, and we check all of that evidence as a quality team.
Thank you, Sarah. I'm going to come to Aaron and then I've got David.
Thank you, Chair. So Sarah's given a really comprehensive view there of the infrastructure that we put around this, but ultimately what we're looking for in trusts is themes that are either indicating governance failure or a breakdown in system and process that we can support kind of closing down. A lot of these never events come down to human factors issues of tiredness and fragility and a mistake made. But we obviously pick up the themes and then share those with the Chief Nursing Group in particular. Just on histopathology, Chair, if I can, on that part of the report, 2 of the trusts in the provider collaborative are now providing mutual aid to the trust that is struggling on histopathology. Just checking in with the recovery plan to the end of March to make sure we've got the back within acceptable limits. It will still be a backlog, but should reduce the exposure to harm highlighted in the report.
Thank you. That's helpful. David.
So I agree when you look at this, first of all, particularly the Quality Committee's alert report, you think, oh my goodness. But remember, we are looking at quite a large geography. We've got 5 acute trusts there. And so the fact is that There aren't a huge number of issues. It would be nice if there were no issues there, and that's what we would strive to get to. But nevertheless, these things do bubble up, and Sarah's quite right. As the system's been under pressure, it's been more of a challenge for some staff. Having the ICB present within the trust quality committees is so helpful, because rather than receiving the minutes, you're part of the decision-making process and you can make suggestions at that point in time rather than kind of being outside. But the other thing is just that for a number of these issues here, there is a point of escalation where we can go to something called a rapid quality review, where we can get the system to help out. So, for example, for histopathology, we knew there was a challenge in one of our trusts, and to get the system alongside and working around that particular trust, we called a rapid quality review. We held it on a Friday afternoon. We got the COOs, the medical directors and the heads of pathology all come along and join us on a Teams call, and in 2 hours we came up with an action plan which is now being driven forward. So we will act when necessary, and that rapid quality review was chaired by the ICB. So we will continue to act, we'll continue to monitor, and we'll be very vigilant. And the final thing, perhaps in some respects, is the feedback I do get from the regional team is they thought the improvement and assurance groups, the IAGs, were very good at picking up some of those quality issues. And that's why they've been quite insistent that quality goes back into them again.
Okay, so, I mean, firstly, Sheena, thank you for the work of your committee in raising those issues. When you presented them, my instinct was that the board might require a formal update, but I'm sensing that do we feel that the process is in place? Give us the assurance. I think we will certainly want to focus on the AAA report of Quality Committee next month at the very least. But I'm looking for board members for guidance as to whether we want anything more than that at this stage. Jim?
Not particularly, but where it said the committee wasn't assured, it would be helpful if the next report said the committee now was assured.
I think that's right, yes, yes.
And I have to say, what I heard was really helpful,
Yeah.
but I don't think that's mapped out anywhere. And somebody should really map that out just from the perspective of this is the, you mentioned the quality governance framework. In effect, that was the quality governance framework, but in a series of pretty easy to understand steps and easy to understand escalations. I just think it'd be helpful for us to have that in almost a more formal setting.
Can we take that as an action? I can't promise how quickly it will get done, but I think if we could take that as an action, that would be helpful. But thank you. Debbie, very quickly.
It's just one probably really obvious point. I'm just reflecting back on the financial position and the system challenges. And I'm just reflecting that moving forward, quality is always absolutely imperatively important, but given the financial pressures in the system, it's something that the board will want to pertain and have particular oversight and assurance against, because that's where the level of risk increases, doesn't it?
Absolutely. Yeah, no, that's right. And it was a useful conversation on that basis. Thank you very much, Sheena. So now we have Finance and Performance Committee. Roy.
Thanks, Chair. Just a nice segue there from Debbie into the financial aspects here. First of all, perhaps it'd be interesting to say a contextual aspect to this, because you can see there's two AAA reports, one from the 9th of December and one from the 6th of January. And the finances, as you'll be aware from comments already made at the beginning of this meeting and throughout the meeting, are a very fast-moving aspect of the ICB's governance and information. And it's really important, I think, that the scrutiny, the consideration of that information is looked at by the Finance and Performance Committee, and that information is imparted to the board in a timely manner. And that's why I say about these two particular committees being at those dates, the information we'll be receiving today on our finance report will supersede, I think, the information that we're giving today in these AAA reports. And that's why I'm saying to you that we're now looking at changing the timings of both the Finance and Performance Committee and the board meeting, so they are much more aligned in that sense. So there is some information here. I don't really want to go through it particularly. I'm sure people have read it, but I think it's really important that it comes to us. And as I said, it's been scrutinised and by that committee. the information is there for you to read. You know, it changes, as I said, from the 9th of December even to the 6th of January. There's a huge change in the amount of deficit that the ICB, ICS is looking at. So I think that that's important for us to recognise, but also that the control targets for 25-26 are also something that we need to be looking at at an early stage, and that is what that's what we're actually doing. So it's really important that we as a board understand that the commissioning targets, the contractual targets that have to be met in 25-26 are being looked at specifically by our executive team, but also overlooked by our non-executive members as well. We have had a helpful update on that commissioning process from Craig, and the fundamental and important part of that is the principle of affordability, and I think that's going to be a word that we're going to be using more and more throughout the coming weeks, months. It's important, I think, that we actually absolutely understand that principle of affordability. Aaron alluded to it earlier in his comments, that the discussions that have been had in the PCB, and I think that's recognised within the PCB. I'm going to stop there, Chair, because, as I said, I'll take those as read, and things have changed in a rapid way. Thank you.
Thank you, and thank you for giving us the sort of up-to-date picture, which is very helpful as well. Any questions for Jim? For Roy. I've got you two in the same place in my head. For any questions for Roy? I've offended everyone now. Any questions for Roy? No. Okay, we'll move swiftly on, I think. Urgent and emergency care. Craig.
Thank you, Chair. So this is the regular update I provide to Board on urgent emergency care recovery during the winter periods. I'm going to take the paper as read, just some comments as in way of highlights. Just first of all, a thank you to all of the staff across primary, community, acute and our partners in relation to support for managing what has been an extremely difficult period over the latter end of November, December, especially the Christmas and New Year period, and it's ongoing into January. So a huge thanks to all of the staff involved, who I think have done a great job in extremely difficult circumstances. This is highlighted as we've had a number of our trusts going to what we call an OPAL 4. OPAL is short for operational pressures escalation levels. They're what we are monitored on nationally, and OPAL 4 is the highest level. And there's a number of actions we have to take when it comes to OPAL 4, stopping some procedures, stopping some outpatients clinics, cancelling annual leave. It's a very extreme set of measures. And we've also had a critical incident at one of our trusts due to urgent and emergency care pressures, and a system response was required. So that just shows how hot the system is running at the minute. I think there are a couple of drivers for that. We've seen an increase in flu, and I don't think we've quite seen the tail end, the middle, and seen it earlier than us. So we predicted sort of the end of December into January. Just as an example, on New Year's Eve we saw flu 4 times higher than we did in the previous 3 weeks. So that's just a measure of, and the complexity and intensity then of our hospital attendance was much more challenging to manage. We've also seen an increase in our handover delays. So that's once the ambulances get to the hospital, handing over to the hospital staff, we've seen an increase in the delay. And it remains me not to mention mental health, who's been under extreme pressures during this period as well. We've done a number of responses. They're contained in Section 2.4, I'm not going to go through them, but they're both sort of place responses, system responses, ICB responses, and that includes oversight, but also actual additional support and help in those places through either local teams or national teams. There has been also more regional scrutiny from NHS England on monitoring our position, and we've responded to that. We've also asked all of our providers to review the major incident plans in light of what has been some other incidents snow, flooding. There's been a range of things, so we wanted to make sure we had assurance in the system. We still have our targets for our target of 78% and category 2 ambulance response time of 30%. Just where we're up to at the minute. Up until November, we were steady at 77.5% for Lancashire and South Cumbria. We've dipped slightly to 76.1%, but we dipped last year and we dipped the year before, and we still recovered the position. And so this ranks us 5 out of 42. So we're still holding our own. And category 2 ambulance wait times, we're at 25 minutes 39 seconds up until December. That's slipped to 35 minutes 26 seconds from the 19th of December. So a deterioration in our response times for category 2. They're the national measures that we need to report on. There's a quick update on the section 4 on our improvement plans, and I now chair our strategic oversight board to monitor each of the improvement plans, and our UEC capacity investment funding we need to consider as a part of our budget setting for next year, so where we look at the capacity funding. The only point I'll say on that is we want to look at the global amount of resource we put into urgent emergency care and not just a single small funding stream, so we want to look at it in a more broader sense. I'll pause there to ask if there's any comments or questions, but I think the report speaks for itself, and just again a massive thank you for everyone in extreme circumstances to still deliver I think what's been a good performance over that period.
Yes, I can see hands just before. I do think the board should put formal thanks to all those involved over the last couple of months in particular, particularly those on the front line. It's been extraordinarily difficult. Thank you. So I've got Chris, and then I saw, was it Julie? Yes.
Thank you, Chair, and thanks, Craig. I think it's a really good report that really highlights the pressure that the system's been under. I wonder if it would be also useful to look at the discharge size. We reference discharges slightly, but just thinking of the numbers of clinically ready for discharge patients across the patch, both in mental health and in acute, whether that and a trend around some of that. I'm just thinking with partner organisations, how we can collectively help to reduce some of those patients that no longer need that acute care, while we've got patients in EDs in the community that need that inpatient care. I think would just be a triangulation on that, if that's okay.
That's helpful. Can we?
So we now have something we call a DSOG, which is a Discharge Strategic Oversight Group that's nationally mandated. That produced a report on flow, including discharge. I'm happy to circulate that to board members, or I'm happy to bring it back to a future board.
I think if we could bring it back to a future board as part of the update, that would be helpful. Thank you. Julie, and then I've got David.
Chair Craig, I realise I'm asking the impossible because in primary care we find this data really difficult to produce. So I just wanted to alert the board to the activity of the local medical committee who've been trying to reflect exactly what you're doing, but across primary care. So just for example, I pulled up a report from the 19th of December which reflected that 523,000 patients were covered by a practice that was declaring themselves to be at amber. And I just wanted to highlight that though that data is very difficult to acquire, that the same pressures are also being seen in primary care, and I just feel that it's not highlighted within that report, but I appreciate that's the technical difficulties of the data collection.
So the obvious follow-up to that is how do we address those technical difficulties so that we can see it, because there's not much we can do about it if we can't see it.
Yes, so there is an ongoing piece of work to look at how practices self-assess where they're up to and what the data we have to triangulate. It is difficult because it is mixed across all of our places and then even in PCN levels. But it's a valid point, and I do think we need to work on a solution, but I can't describe now what that solution is. But I do think even some headlines from primary and community will enhance the report for future. Yeah.
I think that'd be good, actually, if we can just get that in there. David.
Thank you. My question is just around how we engage with the public around the issues when hospitals and the services and primary care are all running really hot and very busy. So I'm just interested to know, are we communicating effectively with the public and giving them advice and guidance on what to do and what not to do? And is that having the desired impact?
So So I think we are doing a lot more in relation to proactive management, and Neil and Dave might want to come in. David does regular updates as the medical director in describing through all of our communication routes what you should do in these times, reminding people of 111, pharmacy first, all of the different elements. We work with our trust communications if there's hotspots in particular trusts to say our A&E departments are very busy and what the alternatives are, what people can do, and then there's regular things about flu, etc., and getting vaccinated. So I think there's a comprehensive approach. You can always do more and do better, but I don't know, Neil, if you want to add anything from our comms approach.
Yeah, I think it's quite a difficult one sometimes when there is always more that you can do. But there is extensive work that's taken place across certainly communications teams, but not just from the NHS, from local authority partners as well. Certainly a lot more that we're doing in place and working with some of our most vulnerable communities, building on some of the connections that we've developed through the work around community wards, through priority wards, to the degree where actually my team have been trained to do blood pressure tests, and as part of the engagement we've been doing throughout September, October and November was doing some of those kind of blood pressure tests as well, to try and support some of our teams to make sure we give people advice and guidance and try and support them. Sometimes we do struggle with the experience that we hear doesn't necessarily lend itself to some of the insights. So I think the work that Craig's doing around that urgent emergency care transformation, making sure those experiences are really built into what a future system and service will look like is really important. So yeah, I think there's a lot of work that's going on. There's a lot of communications engagement, work with the media and others, and I think partly that sees it in some, it's difficult to manage and monitor the impact that has as well because of the number of complex factors, but happy to kind of give more update to the board about that going forward. But yeah.
Thank you, Neil. Do we ever use the NHS app as a way of communicating? I mean, I know it, given the patient story, I know it won't work for everybody, but sort of more specific communication saying we are very busy at the moment, or GP practices are very busy at the moment.
So some practices have a triage system, and what they will do is they'll change the message that a patient will receive when they send in a query, for example. For other practices, the use of the app is very dependent on the patient having activated the notifications section, and then finding somebody who will provide that messaging service. But yes, that is entirely possible. It would just need coordinating.
Okay, thank you. Good. So, my question around clearly we're very hot at the moment, and there's been an enormous amount of work, and I think congratulations are, I mean, that's not probably the right word, but people have achieved an enormous amount under immense pressure. When we looked at the urgent and emergency care plan and the delivery of the changes, I guess in hindsight, this wouldn't be the time we'd be wanting to try and implement that, would it? Presumably the plan is to continue this into the next financial year, isn't it? Yeah.
So we were very mindful when we agreed the plan of how much we could deliver in Q3 and in Q4, or at least part of Q4, which is why we're not seeing some of the traction on some of the improvements. We are seeing some stabilisation though rather than deterioration, which I think is a positive. But these plans didn't have a sort of annual end date. I think they need refreshing because they've replaced our requirement to do a separate winter plan, which is what we've always been accustomed to doing. So we want an ongoing year-on-year improvement plan for UEC that links to patient flow, it links to access, it links to responsiveness, it links to discharge, and it's underpinned by the affordability. So I think that's something that we would want to continue with rather than say we've done our plan for 24-25 and we'll do a new plan for 25-26. I've just not got yet the support of all the providers because we've not had the board meeting yet to discuss it, but I would imagine, I'm looking to Aaron, that there would be general support because I think they found this focus very helpful and supportive.
Aaron?
Yeah, just a distinction, I guess, between the winter plan and general UEC improvement. So I think our approach to winter planning has matured over iterative years, and we're much better now at what I would call getting a bang for your buck with the additional investment that comes in. I'm going to sound like a broken record now, but I think when we build the individual components of the papers we've seen today, we've referenced clinical configuration, population health improvement, we've referenced UEC, transform community care. We need to start to turn these into delivery plans where we can understand the cause and effect, because we'll build a model of demand and capacity that will really help with the improvement on performance and financial sustainability. So one of the things to look for, Chair, in February, March is the component parts of the plan where we've got improvement programmes. What's the resource and what's the impact we're expecting, so providers can start to reflect it in their plans, and we're not quite there yet.
Okay, but we hope to be there in February, March, so, and that will come back to the March board, as presumably as part of the commissioning intentions.
Yes.
Connected, yeah, but it will, yeah, okay, fine.
I was trying to work through my head.
Yeah, no, that's fine, thank you very much. Anything else on that? Sakthi?
Yeah, just to complete the picture here about the winter planning, and Craig mentioned flu being one of the primary drivers of this. It is really surprising that the level of flu vaccination uptake is actually going down year by year, and especially so in our workforce. So as part of next year's planning, I think we missed the boat this year in some ways. We really ought to be understanding this better and doing something about it, because we know it's effective. It can reduce the severity of infections and therefore people turning up there inside the hospital. Linked to that, as again over the last 2 years, 3 years particularly, if you look at how the flu vaccine system, the supply system has changed, it's become very fragmented between pharmacies and primary care. You try and book online now. We're still in flu season. You can't get book online now, even for those that want it. And the appointments have all been squeezed so that it's commercially viable over the weekends or one slot. So we've got to look at this part of the system as part of the winter planning even more robustly next year. We are unfortunately going to see excess winter deaths reported from this winter increased. So I just can't overemphasize that element, which is entirely preventable. We need to do more as a system. Thank you.
Thank you, Sakthi. I couldn't agree more. Okay, let's move on. We have now got finance report. Andrew.
Thank you. I'll take you through the key details of the report, if I may. So paragraphs 1 and 2 talk about the deficit target for the system of £175 million that's been supported by NHS England now. We remain £62 million behind plan on that position, of which the ICB represents 7 million and our constituent providers represent 55 million. A reminder that this position requires £530 million worth of efficiency, and the year-to-date says that we're 38 million behind plan, but the high risk in the system associated with this is that a lot of those savings are back-ended, and therefore we're expecting a higher level of delivery of those savings plans, those efficiencies, within the final quarter of the year, so that makes it high risk at this point. The other point that I wanted to raise is that we have 2 special payments referenced in the report. So the ICB has a special payment, losses and special payments register, and it's the responsibility of the board to sign off those payments. In these 2 particular instances that are addressed in the report, due to the time sensitivity of the payments, one relating to an ombudsman finding which often only has the ICB having about 14 days to make the payment, and the other relating to the travel costs for a patient who was moved out of area, and therefore the expediency of that family being able to continue to visit the patient required executives to sign those off. So we're looking for approval from the board in line with the scheme of delegation to sign off those 2 payments of £550 and £4,320 respectively. Thank you, Chair.
Thank you, Andrew. Questions for Andrew on the finance report? Jim?
I'm happy with the payments, by the way, so got no issues on that. Just in respect to the position, Roy went through the finance and performance AAA report before. One of the things that was mentioned in that, which isn't in this paper, is that the consequence of the overspending is quite significant for cash. And we are, as a system, I would say we're running out of cash, but cash is becoming extremely tight, and that will have to be watched very closely as we get to the end of, towards the end of March. So just to make that comment basically, and to have it noted in our minutes if we could.
Yeah, thank you, thank you. Okay, any other? Yes, Julie.
Chair, my apologies. I just query again that primary care isn't displayed on the summary financial position. It's based on trusts, is it not?
Sorry, could you repeat it, please? Sorry, I didn't quite.
I may be incorrect, but when I look at the financial position, I can't see primary care as a line. Where are they accounted for? On there?
Primary care is in there, sorry. Is it about where primary care sits?
Yeah, on table 1 and...
Can I partly answer this? When we go to the Finance and Performance Committee, we get a full breakdown of the ICB's budget, which includes the primary care lines. So we look at it in more detail within the Finance and Performance Committee. And at the board, we tend to just look at the almost the summary position and the CIPs, which is where most of the focus is at the moment, basically. So you're right, there isn't a mention of primary care in this, but it is covered in the Finance and Performance Committee.
And the detail that Jim refers to is all captured within the ICB line within the table in the report. So that includes everything within there that the ICB commission. Apologies, Julia.
That's table 2, Julie.
Okay, any other questions? I mean, there is clearly an enormous amount of work, rework, scrutiny, and rework and re-scrutinising of the position at the moment. It is very tight, and that will continue to the end of the year. So, to a certain extent, it's a very movable feast. Okay, I'm going to move us on then, since I'm not seeing any other hands, onto the Integrated Performance Report. Asim.
Thank you, Chair. Many of the areas I was going to cover have already been covered. So UEC has been covered, and SACTE has picked up the issue around flu, which I might cover at the end. But I think, just reflecting, since I've been presenting the performance report, it's been a year plus now, I always start off with, we have seen an increasing demand compared to the previous month or previous period, and it's no different this period. And as we've seen in the Chief Executive report and the report that Craig has just presented, in some of our services we have not seen demand as ever, so since records have begun. So I think we need to recognise that. So, for example, in elective cases have increased by 13.2% compared to last year. A&E attendance is 6.4%, cancer referrals 11.7%, and the list goes on. So we've seen significant activity and increases. And recently, I have witnessed firsthand sort of the challenges and pressures. And what you do see is the compassion and the dedication of our staff. And sometimes when we present these reports, there's facts and figures, green and red. But I think it's really important to acknowledge the efforts of our frontline staff that they put in these challenging times. I will take the performance report as read, but there's a couple of areas I will want to pick on. Firstly, elective recovery. And just to, I think it's opportune to remind ourselves that before the pandemic, we had approximately 125,000 people on the waiting list, with 105,000 people, they were waiting up to 18 weeks, 83.2%, with very few waiting over 52 weeks. So now we've seen the plan for reform for elective care, which was published on the 6th of January, which refocuses our attention on 18-week referral to treatment constitutional standards. And there's some milestones in that which we need to build in. So by March 2026, the percentage of patients waiting less than 18 weeks need to be 65%. We currently stand at 60.8%. And each trust needs to deliver a minimum of 5%. And that's across the piece. But I think it's quite timely, and the maths actually add up for us, because we're 60% and we need to meet 65% by the end of next year. And I think it's also important, we had a paper on health inequalities. What the pandemic saw was access to elective care reduced dramatically. I've just been through. But we also saw a widening of health inequalities, and we've done some good work around in this area. And what we do see, people in more deprived areas are waiting longer. So when we do our plans, I think it's important that we restore our elective care inclusively. And there's a lot of data, and it's not one analysis across all services, yeah, but in many of our services, people from more deprived neighbourhoods are waiting longer to access some of our services. The only other area I'm going to sort of highlight is our mental health out-of-area placements. And as colleagues are aware, the boards are aware, I've sort of mentioned this before, there's a financial cost to out-of-area placements, but even more importantly, there's a quality and outcome cost, because the more distance people are and they are away from their usual support networks, it does impact on their recovery. And we've seen sustained improvements over the year from Lancashire and South Cumbria Foundation Trust. So at the beginning of the year, we had 35 patients in inappropriate out-of-area placements, and within this reporting period, there were 6 patients. But what we have seen is an increase due to the winter pressures. And I think it's good to see that there's a lot of interventions around prioritisation and focus, looking at the super-stranded patients and winter planning length of stay reduction. I'm going to leave it there because quite a lot of the areas have already been covered, but happy to answer any question with support from my other executive colleagues.
Thank you very much, Asim. Any questions for Asim? No? No? Yes, Roy.
It's not a question, Chair, but it's a comment actually on the non-medical criteria to reside. And I was looking at some figures the other day, and it's specifically for Aaron, I think, this question. The figures of patients in G&A beds with a non-medical criteria to reside was quite high when I looked at it. But then within a month or two, you'd managed to bring that down significantly. I think it'd be interesting for us to hear how you were able to do that, because I've never been able to understand how we've been able to understand that. And you know, I think it's, if we could share that data, if you could share that information around, you know, other acute trusts, and I'm sure you do that already through the PCB. But I'd like to just hear how you were able to do that.
Thanks, Roy. I think it's important to acknowledge that even today, our not meeting criteria to reside numbers are still in excess of 20% of our bed base, so still the worst performing system in our system. So I'm cautious about what I'm about to say. So we've started from a very poor baseline, and we've got better in one area of the patch. So this is the work that I think we've referenced before, which is the wellness centre and the intervention, which was co-created with place, acute, community and general practice, which has resulted in a material shift in not meeting criteria to reside numbers in Barrow, in Furness General Hospital. So a combination of therapies improvement in the hospital, much better discharge support and hosted arrangements within local authorities and place, and it's being sustained. So that's a really good news story for Furness General Hospital. We have been unable to replicate that in Royal Lancaster Infirmary, and yesterday I think there were nearly 32% of beds at the RLI occupied by not meeting criteria to reside. So it's an immediate kind of piece of work we prioritise with ICB in place to see what is it that's blocking us from replicating in that part of the world, to see if we can get a similar impact.
It's a really interesting exchange. I would really like to understand what you find out about that at the next board, actually, because if you can't replicate it within your trust, we haven't got much hope of doing it across the system, have we, unless we work those blockers out. Sarah.
Yeah, thank you, Chair. I nearly came in and commented before when SACV raised about flu vaccine, and I didn't, but then listening to Asim refer to it again, I was on a national call last week, a national nursing call, where it was also discussed, because it's the population, but it's also the workforce. And I know in some of our social care providers over the last few weeks, we've had nearly 40% sickness. So, you know, we're here as a system facing this massive financial distress, actually, but the financial cost of flu on both our workforce and on the population getting ill, and then the cost of that is huge. So I suppose it was do we need to take a more determined action or ask for a more determined action as a board, that we almost set up a bit of a task force now for how we go into this year to go into next year, where we really do have a think about how we raise, and it's probably, we've got an issue across a number of vaccinations, but I think we could really target flu across our health and social care providers, and also our staff are our local population, aren't they? So but I think we probably felt a little bit like maybe did we skirt over it, and I think actually it's an area of prevention that obviously for outcomes is good, but actually could save us quite a lot of money.
I'm never going to say no to that. Yeah, are we agreed?
I completely support and very happy, myself and group of directors of public health. There's a lot of work happening. I think next year we have an opportunity to really properly focus on this one with trust colleagues, social care, across the system, Chair. Very happy to work with Sarah.
Excellent. So we'll put that as an action. It doesn't need to come back to next board particularly, but we will want it, perhaps the one after that. Yep, great.
That's about co-production as well, because you know it's really seeking to understand why people don't. What is the driver behind poor uptake?
Yeah, absolutely.
Because we can do all the measures we like, but actually it's getting underneath that behavioural aspect of it that's really key.
So I'd suggest Neil's involved in that as well. Yeah, and Debbie, I suspect. Asim?
And I think there's a inequality lens here again. So if we look at the GNA bed occupied by flu, East Lancs and Blackpool are sort of the highest. And if we look at flu vaccination across the country, I believe, I've not got the data in front of me, these areas where there's the poorest uptake of flu, and these are very sort of deprived areas. There's a ethnicity sort of challenge around flu vaccination, so it's not necessarily going to be a quick fix. So I agree with you, Sakti, we need to start quite early on with this.
Great, thank you very much. I'm going to move on. We are now entering the governance section, and the first item is the Escalation and Assurance Report from Audit Committee. Jim.
Thank you. I think the only thing to mention really is that we had 6 completed audit reports presented to us, and one of them, the one related to all age continuing care, had 5 high priority recommendations, and we're going to monitor those hopefully through the Quality and F&P committees. Beyond that, we're in a relatively quiet part of the year for the Audit Committee. So it was a relatively straightforward meeting this time.
Thank you. Any questions for Jim? No, then let's move on to the North West Specialised commissioning arrangements. Craig.
Thank you, Chair. So I'll take the cover paper as read, and also the appendix one, which I'm hoping everyone has read the delegation. This is just to remind everybody that we've already got delegated specialised commissioning services that started from April 24, and they are related to where there is single ICB leadership and also multi-ICB leadership. We have a Lancashire and South Cumbria Specialised commissioning oversight group that David and I co-chair, and we also have a joint committee across the 3 ICBs and NHS England that Jim and I both attend. Partly to say that the work is ongoing. The North West Specialised Commissioning Hub, which is under Section 2, is looking to transfer to us in Lancashire and South Cumbria as the host ICB on behalf of the 3 ICBs, and the date for that is the 1st of July. There's a lot of work ongoing in the background about structures, transfers, what's going to be a lean in from NHS England, what's going to be a retention from NHS England. So the goalposts have moved slightly based on what services are being retained and not, and I'll need to bring something more formally back, because when we very initially agreed to do this as a board, the board wanted assurance regarding adequate staffing and resourcing to do this, and I think I need to come back with that assurance. So that is to be produced in the future. There's also further delegations happening, 25 from April this year. And under Section 3, there is an element in relation to health and justice, armed forces in Section 7A that will be included in the ICB's contract work. We do need support for the financial and contractual arrangements that weren't in the initial agreement. So that is a specific ask of the board today. But also in relation to the delegation agreement that's included in the appendix, this is a boilerplate one that is produced nationally. I'm confident Deborah, in her role, has crawled all over this and has given the assurances required and pointed out some things that there were errors on. So I would want the board to formally accept this as it's required for us to be able to have further delegation from next April. And I'll pause there and answer any comments or questions, or Jim will. Any difficult ones to Jim?
Thank you, Craig. It wasn't the clearest document in the world, that delegation agreement. Sheena.
Two things I want to pick up, if I may. First of all, and again, it does go to it wasn't the clearest document. One of the things that are clearly really important, as well as we've seen throughout the meeting today, is about understanding the quality of services commissioned in this way. And I wasn't entirely clear how that's going to be delegated, and that's going to work through. We have started to pick this up. We have got a member of Specialised Commissioning has now joined our quality subcommittee, but I really just wanted to seek to understand even better how that's kind of envisaged, really. Thank you. Do the second point, because it's completely different in a minute, if I may. Thank you.
Just come back on that particular point, Chair. So this is one of the areas that we're currently in, I wouldn't say dispute, but negotiation, as the proposal is that NHS England will retain the quality elements from a leadership but delegate the quality team to us in Lancashire and South Cumbria. And I think that needs further conversation between myself and Sarah and NHS England's regional team, because looking at the proposal, I think that potentially might leave some vulnerability and risk, and therefore I've not supported the current structure until Sarah can give me assurance that she's content with the arrangement. So I think that is still an area to be agreed, Sheena.
Yeah, so that then leads me, if I may, Chair, to actually how we might want to agree this as a board, given the fact we haven't got that final clarity around that. And also Craig's going to say he'd come back about the assurance around sufficient capacity being...
Yeah, I agree with you. I agree with you.
England.
And I think this isn't to try to be difficult, Craig, but it is. I was going to say that I would need, as chair of this board, I would need to know that the Quality Committee was assured as to the quality assurance processes in some form. So I don't know how can we do that without being difficult.
So we already have a significant proportion of delegation. Yeah. So this is some smaller delegation and an amended delegation agreement. So I think what we're asking for is, before the hub is transferred, because we could still have them delegated and the hub not be transferred and that be retained by NHS England. So I'd like to agree the delegation agreement, but come back with further assurances on the hub arrangement, if that's okay, Chair.
Very sensible.
Yeah, that feels okay.
Yep.
The second bit, and again, was about a bit of clarity. So on 176 of the pack, it mentions about mental health specialised commissioning. And as you know, we've already got some delegations through Specialised commissioning into provider collaboratives for mental health. And I just wanted to just check in my mind whether this impacts on that or not. Thank you.
Chris is probably best to answer because he's been more involved in the discussion.
Yeah, sure. So across the Northwest, we've got a range of mental health provider collaboratives for SpecCom services. They are being looked at the moment, so each mental health trust is reviewing where they sit at the moment and whether they should be reviewed as to a regional base or an ICS base rather than some of what we've got at the moment. So that there will be changes that will likely come forward, and we'll make sure Craig and the team will be fully involved with that, as well as the provider trust and NHS England.
Is it possible to have that backup board at some point then, if we may? Thank you, Chair. Thank you.
Within the same sort of timescale, would that be sensible to have another paper, or is it two different sessions?
I can include it in a Specialised commissioning update, which will be the lead provider model as well as the hub, and I propose if that's going to transfer for July, it comes either in the May or June board, depending on what's... I'm out of sync on what's public and what's not.
We all are. Yeah. No, okay, I think that sounds sensible. Does that make you happy, Sheena? Yeah, great. David.
My point was back to the quality element. We already saw as Specialist Commissioning came across that as we as the ICB had that delegated authority, we had that oversight. And it's good that it comes to the Quality Committee, but I think as Craig's highlighted, as more services come across, we need to be aware of the people and the team that will come across to support us with that, because I'm not quite sure if that's how much is going to come across. And there are more services now being delegated, including thrombectomy, and I think we just need to, as we have in the past, just perhaps kick the tires to make sure we understand what we're taking on.
Okay, and can that be part of that same discussion in May, June? Yeah, no, fine. I think that would be quite a substantive discussion then. Great, okay, thank you. Any other comments? No, thank you. So I'm going to ask the board to approve the variation in the delegation agreement. Yes, that's fine, and we'll look forward to the paper in May or June. And finally, annual review and publication of conflicts of interest registers. We need to approve the annual review and publication. I'm going to hand over to you, Deb.
Thank you, Chair. I'll take the report as read. Conflict of interest policy requires that we do an annual review and publication of declarations of interest for board members, committee members, and those that are defined as decision-making staff under the policy. Internally, the RCB holds a full register of all staff, so that's not what you'll see within this report. It also provides the RCB's Gifts and Hospitality Register and Procurement Decisions Register, and there's also a section on how we implement this policy and how we support staff across these statutory requirements. And then just really to highlight NHS England, they provided NHS organisations with access to training in February last year, and our ICB adopted that training module as mandatory. It's not a statutory mandatory requirement, but we've adopted that as mandatory for our organisation, for all staff, and we're expecting NHS England to share two further modules. One will be more specific around those decision-making staff, and they're looking at a module for NHS chairs as well. So as soon as we see the finalised detail on those, we'll look to implement those as mandatory too.
Great, thank you very much. Deb, any questions? Are we happy to approve? Yes. Okay, does anybody have any other business for today's board? No? In which case, thank you. Thank you to those people that have observed us over the last 2.5 hours. That's dedication. And thank you to board members, both for the production of some good papers and for a fulsome discussion. So thank you very much indeed.